Usually when we talk about getting a medical diagnosis, there is this, there's this very comforting expectation of precision, right?
Absolutely. Yeah.
Like you break your arm, the x-ray shows that jagged white line, the doctor points to the screen, and boom, you have your answer.
Right. The problem is isolated.
Exactly. The evidence is visual, and the path forward is just, standard protocol.
Which, honestly, it creates a false sense of security. We're all conditioned to believe that if a disease is real, modern medicine can just instantly map it, image it, and measure it.
But then you step into the world of chronic, invisible, multisystemic illness. And suddenly that expensive x-ray machine is, well, it's completely useless.
Yeah, it really is.
And for so many of you listening right now, this scenario is going to sound deeply, frustratingly familiar.
Oh, I'm sure it will.
You spend decades, literally decades, bouncing from specialist to specialist. You have this massive laundry list of symptoms that, at least to the untrained eye, just seem totally disconnected.
Right, like they couldn't possibly be related.
Exactly. We're talking chronic joint pain, severe digestive paralysis, dizzy spells every single time you stand up, maybe even neurodivergent traits, like autism or ADHD.
Yeah.
And instead of getting an answer, you're repeatedly told that your blood work is perfectly fine.
Which is just the most validating and invalidating thing all at once.
Right? You're told it's all in your head. Or you get the classic fallback. It's just anxiety.
Oh, the anxiety label, which just leaves patients stranded. They are forced to navigate this incredibly complex, cascading medical reality entirely on their own.
Yeah.
And they're constantly second-guessing their own sanity, really, because the very institutions they trust are just outright dismissing their pain.
Well, today, that is our mission. This deep dive, we're pulling apart a massive stack of evidence. We've got the highly anticipated Petrucci-Nelson genetic study, the clinical insights in Diana Jovan's comprehensive book, Disjointed, and the latest clinical guidelines on hypermobile Ehlers-Danlos syndrome, or hEDS.
It's a lot of ground to cover, but it's so important.
It really is.
Yeah.
We are moving past the gaslighting and looking at the actual molecular proof. So let's unpack this.
Let's do it.
We all know that hEDS basically destroys connective tissue. But for decades, the medical establishment treated it like a ghost.
Right, because they couldn't find the smoking gun on a DNA strand.
Exactly.
Until now.
And, this is what makes the historical context so incredibly important here. There are 13 recognized Ehlers-Danlos subtypes.
Right, 13 total.
And for years, 12 of them had identified genetic markers. But hEDS, which is the most common subtype by far, by the way, was the only one missing a known genetic cause.
Which is wild when you think about it.
It is. So it had to be diagnosed purely by clinical observation, looking at joint hypermobility, skin hyperextensibility, tissue fragility.
And without that genetic anchor, the medical system just struggled to validate it. They want a lab test.
Exactly. Which brings us to the actual breakthrough, the Petrucci-Nelson Genome-Wide Association Study, or GWAS, as it's known in the field. Right? And for those of you tracking this at home, a GWAS basically scans the entire human genome across thousands of people. It's looking to find tiny variations that are common in people with a specific condition.
Yeah, and in this case, they looked at over 1,800 hEDS cases against thousands of healthy controls. And spoiler alert, they actually found the markers.
Thank God.
Right. What's fascinating here is the specificity of what they uncovered. They identified 2 key loci that reached genome-wide significance.
Okay, lay it on us.
So the first is a regulatory region near a gene called ACKR3. The risk alleles in this region actually alter enhancer activity, which creates a new transcription factor regulatory site.
Whoa, okay, I'm going to stop you right there because transcription factor regulatory site is a total mouthful.
Fair enough, yeah, it's very technical.
What does ACKR3 actually do in the human body? And how does altering it lead to the agonizing pain so many people experience?
Well, that is the critical question. So ACKR3 is heavily involved in neuroimmune signaling and pain pathways. The study found that these genetic variants co-localize with gene expression, specifically in the tibial nerve.
Wait, really? So the nerve itself is behaving differently?
Yes, exactly. This implies that the pain in hEDS isn't just a secondary result of, joints slipping out of place and rubbing together.
Oh, wow.
Yeah, the peripheral nervous system itself is structurally predisposed to generate and amplify pain signals.
That is huge for anyone who's been told they're just exaggerating their joint pain.
Absolutely.
Okay, and what was the second major finding?
The second locus contains the SLC39A13 gene.
Which does what?
It's a zinc transporter.
Okay, why zinc? I mean, people take zinc for a cold, right? How on earth does a zinc transporter cause your shoulders to literally dislocate?
It comes down to how the body manufactures its structural support. So connective tissue relies heavily on collagen.
Right, we hear about collagen all the time in, like, skincare.
Right, but internally, to build strong collagen fibers, your body uses specific enzymes to cross-link those fibers, to bind them together tightly.
Okay, making them strong.
Exactly. And zinc acts as a vital structural cofactor for those enzymes. So if your zinc transporters are faulty due to this genetic variation, the enzymes can't do their job.
And the collagen fibers don't cross-link correctly.
You got it.
So if we use the classic analogy of connective tissue being the mortar between the bricks of the human
I
body,
love that analogy, yeah.
a faulty zinc transporter basically means the mortar never actually sets. It just stays soft and crumbly.
Exactly. Or, actually, a better way to look at it might be like a suspension bridge.
Okay, tell me more.
Normally, the cables holding the bridge up are made of solid steel. But for someone with hEDS, this genetic variant means their bridge was built using bungee cords.
Oh, man. That is such a vivid visual. Bungee cords instead of steel.
Right. And because connective tissue is the most abundant tissue in the human body, I mean, it wraps your blood vessels, it lines your gut, it holds your organs in place.
So those bungee cords are literally everywhere.
Everywhere. So when the infrastructure is that unstable, every single system in the body has to work overtime just to keep the bridge from collapsing.
For anyone listening who has hEDS or, maybe knows someone who does, I really want you to take this in. This is the ultimate validation.
It really is.
It proves in black and white that this condition is molecular. It is a genetic reality. You aren't making it up, and it is definitely not a psychiatric manifestation.
Oh, it's coded into your DNA.
But, okay, if the DNA evidence is sitting right there in the cells and the structural failure affects the entire body, I have a really hard time understanding the timeline here.
The diagnostic delay.
Yeah. Why does the source material explicitly state that it takes an average of 14 to 28 years for some patients to get a diagnosis? That is wild.
It is wild, and that diagnostic delay is arguably the most tragic consequence of how our medical system operates.
Wow.
To understand the why, we really have to look closely at the demographics.
Yeah.
The data indicates that hEDS affects women at a much higher rate than men. It's roughly a 3-to-1 ratio.
Wow. Okay.
And when you isolate that diagnostic delay by gender, a glaring disparity emerges. Men wait an average of about 4 years from the onset of symptoms to a correct diagnosis.
4 years is still a long time to be in pain, but...
It is, but women wait a staggering 16 years.
16 years.
Yeah.
That is an entire childhood and adolescence.
Yeah.
Or, a massive chunk of a person's adult life just spent suffering without an answer.
Decades of their life, yeah.
Let's dig into that. Why the massive gap? I mean, is there a biological reason like estrogen making the joints even more lax? Or is this entirely a systemic failure in how medicine treats female bodies?
Well, the sources address this head on. While hormones like progesterone and relaxin certainly do exacerbate joint laxity in female patients.
Right, they loosen things up.
Exactly. But the authors were examining like Maya Dusenberry in Doing Harm and Caroline Criado Perez in Invisible Women. They present a very compelling, data-driven argument that this delay is heavily rooted in systemic medical bias.
Okay, let's lay out their argument for the listeners. Because they point out that historically, the baseline of normal in medicine was modeled almost entirely on men, right? We just want to report what the texts are saying here.
Right, strictly looking at the evidence they present. For decades, clinical trials frequently excluded women.
Because of hormones.
Yeah, the rationale was often that female hormonal cycles were just too complex and would muddy the data. They thought it would make it harder to establish a clean, standard baseline.
Wow.
Consequently, the authors argue that our diagnostic criteria, our understanding of disease presentation, and crucially, our models for pain processing, were built almost exclusively around male biology.
So if we follow that logic, when a woman walks into a clinic with complex, diffuse symptoms that don't neatly align with that male-centric diagnostic algorithm.
The system simply doesn't know what to do with her.
And there's this chilling anecdote in the Disjointed book that perfectly illustrates the danger of this blind spot.
Oh, I know the one you're talking about.
Yeah, there was a female patient suffering from craniocervical instability, which means the bungee cords in her neck were so loose that her skull was literally not stable on her spine.
Just terrifying.
Right. She also had severe autonomic dysfunction. And she eventually looked at her medical chart from early in her journey, and a provider had simply written weak woman as her primary diagnosis.
Weak woman. It is a profound failure of investigation. The authors in our source material emphasize that when a disease is multisystemic and the patient is female, the historical default in the medical community has often been to label the issue as hysterical or psychosomatic.
Rather than searching for an underlying physiological mechanism.
Exactly.
Which brings us to the snowball effect. If a woman is dismissed for 16 years, she isn't just dealing with a bit of joint pain anymore. Over a decade and a half, those untreated genetic predispositions cascade into a massive crisis.
They absolutely do. And the Petrucci-Nelson GWS study mapped this out by looking at genetic correlations.
What did they find?
They found that hEDS shares a biological architecture with a host of other debilitating conditions. We're talking myalgic encephalomyelitis, fibromyalgia, severe gastrointestinal diseases, migraines, and depression.
Okay, and here's where it gets really interesting, especially regarding neurodivergence, because that same study found a significant genetic overlap between hEDS and autism spectrum disorder.
Right, and the clinical community has known anecdotally for years that there is a remarkably high prevalence of neurodivergent traits, specifically autism and ADHD, in the hypermobile population.
But now there's proof.
Yes, what's changing now is that the genetic data is finally backing up those clinical observations.
So you have patients dealing with AuDHD on top of what the sources call the EDS trifecta. And we really need to break this trifecta down because this explains the absolute day-to-day misery of living with this condition.
It really is the core of the daily struggle.
The trifecta is hEDS, POTS, and MCAS. Let's start with POTS.
So POTS stands for postural orthostatic tachycardia syndrome. Basically, it is a disorder of the autonomic nervous system.
And how exactly does faulty collagen cause a nervous system disorder? Like, what is the mechanism there?
Well, think back to the bungee cords we talked about.
Okay.
The walls of your blood vessels are lined with connective tissue. When a healthy person stands up, the blood vessels in their legs constrict, which pushes the blood up to the brain against gravity.
Makes sense.
But in hEDS, those vessels are too stretchy, they dilate instead of constricting, and the blood pools in the lower extremities.
So the brain is suddenly starved of oxygen.
Exactly, and the body panics. The heart has to rapidly accelerate its pumping to force that pooled blood back up to the brain.
Just to keep you conscious.
Right, and this triggers a massive dump of adrenaline.
It's sort of like a thermostat that's been wired backward. The harder the body tries to regulate the temperature, the more the furnace just blasts and the system just totally overheats.
That's a great way to describe it.
Which leads to the third part of the trifecta, MCAS, or mast cell activation syndrome. Now, mast cells are the immune system's first responders, right? They release histamine to fight off threats.
Yep, they're the sentinels.
So what is the biological bridge between stretchy joints and an overreacting immune system?
It lies in the structural matrix itself. Mast cells live right in the connective tissue.
Oh, I see.
Because the hEDS connective tissue is constantly stretching, micro-tearing, and failing, it is continuously releasing inflammatory damage markers.
So it's always sending out distress signals.
Constantly. The mast cells are sitting in this matrix, surrounded by constant tissue damage, and they misinterpret it as a massive ongoing attack.
Wow.
So they become hyperreactive. They're constantly degranulating and dumping histamine into the bloodstream, which causes allergic-like reactions, flushing, and systemic inflammation.
You know, the book Disjointed includes quotes from a teenage girl living with this exact combination. And honestly, it makes the clinical data feel so viscerally real.
Her quotes are incredibly powerful.
She describes waking up with dysautonomia as an immediate adrenaline rush, right into fight or flight. She said it feels like her organs are literally sinking.
Just horrible.
And she describes the brain fog not as just being sleepy, but like swimming through cement.
Yeah.
And because her hypermobile joints don't send the correct proprioceptive signals to her brain about where her limbs are in space, she said walking feels like a virtual reality video game where there is no floor.
That lack of proprioception, when you combine that with the relentless adrenaline of POTS and the inflammation of MCS, it places the body in an unbearable state of high alert.
It sounds exhausting.
It is. And this triggers a phenomenon known as central sensitization.
Okay, I'm going to play devil's advocate here for a second.
Go for it.
Central sensitization sounds suspiciously like a shiny new clinical buzzword for you're too sensitive or, you know, it's all in your head. Are we absolutely sure this isn't just the medical community finding a slightly more polite way to write weak woman on a chart?
That is a very fair critique, and honestly, it's a danger that patients are highly aware of. But biologically, central sensitization is a measurable physical adaptation.
Okay, how so?
Think of the nervous system as an audio amplifier. If you constantly feed it a signal that is far too loud, in this case, years of joint subluxations, chronic inflammation, and adrenaline surges, the amplifier's baseline gets permanently turned up.
Oh, so the volume is stuck on high.
Exactly. The nervous system physically alters its pathways to become hypervigilant. It starts interpreting normal sensory input, like a normal touch or a bright light or a loud noise, as a painful threat.
Which perfectly explains why these patients are so often misdiagnosed.
Yeah.
I mean, a doctor sees a patient who is overwhelmed by fluorescent lights in the clinic, anxious from an autonomic adrenaline dump, and complaining of diffuse full-body pain.
And what do they see?
They diagnose them with a purely psychiatric anxiety disorder, entirely missing the faulty collagen that triggered the whole cascade in the first place.
Right. The outward presentation mimics a psychiatric condition, but the root cause is structural, genetic, and neuroimmune.
So, if you are listening to this right now and you are having a profound aha moment, what happens next?
That's the big question.
I mean, when you combine the genetic reality, the 16-year delay caused by gender bias, the interconnected comorbidities of the EDS trifecta, and the overlap with AuDHD, you have a massive population of women who are only finally getting the correct diagnosis in their 30s, 40s, or even 50s.
Yeah, late in life.
How does an adult even begin to navigate a paradigm shift that massive, that late in life?
If we connect this to the bigger picture, receiving a late-in-life diagnosis of hEDS, often alongside a late discovery of autism or ADHD, is an incredibly complex psychological and physical transition.
I can't even imagine.
In Disjointed, the chapter by Carrie Gabrielson tackles this directly. She explains that a late diagnosis requires an exhausting amount of unlearning.
Unlearning what exactly? Like habits?
You have to unlearn a lifetime of compensatory coping mechanisms. When you live with undiagnosed hEDS, your body subconsciously figures out ways to prevent your joints from dislocating.
Oh, right. Like bracing yourself.
Exactly. You lock your knees, you tense specific muscle groups continuously just to hold your skeleton together. But those very movements cause severe long-term muscle dysfunction.
Because they were never meant to be used that way.
Right. And mentally, you have to unlearn the internalized narrative that society placed on you, that you were just lazy or weak or making excuses all those years.
There must be an immense amount of grief wrapped up in that unlearning. I mean, grieving the decades you spent being dismissed.
So much grief.
Grieving the physical damage done to your body by doctors who prescribed standard physical therapy that actually made you worse. And honestly, just processing the sheer anger of realizing you were right about your own body all along.
Yeah, and processing that grief is absolutely essential. But Carrie Gabrielson and the clinical guidelines also lay out highly actionable physical strategies for taking back control.
Okay, what do they recommend?
The absolute priority is building a multidisciplinary medical team that actually talks to each other. You need a primary care provider to act as the quarterback.
Yeah.
But critically, you need an EDS-informed physical therapist.
We have to underline that distinction. Why is a standard physical therapist dangerous for an hEDS patient?
Because standard physical therapy is designed to increase range of motion and stretch tight tissues.
Right, for normal folks.
Exactly. If a PT treats an hEDS patient like someone recovering from a standard sports injury and aggressively stretches their joints, they are stretching bungee cords that are already failing.
Oh, making them even looser.
Exactly. An EDS-informed PT focuses on isometric strengthening, building the micromuscles around the joint to do the job the faulty connective tissue cannot do.
Okay, that makes total sense.
Yeah.
You also need an occupational therapist for joint protection strategies and specialists who actually understand the mechanics of POTS and MCS.
Yep, a full team.
But beyond the clinical team, there's a vital mental framing component mentioned in the material. The sheer transience of hEDS is terrifying. I mean, you can feel totally fine on a Tuesday morning and be entirely unable to stand up by Tuesday afternoon.
It's the unpredictability that breaks people. To cope with that, the authors actually recommend a specific framework found in Pema Chodron's book, Comfortable with Uncertainty.
Oh, I've heard of that one.
It's excellent. It provides tools for learning how to ride the unpredictable waves of a dynamic disability without letting the panic of not knowing how you will feel tomorrow pull you under today.
I love that, just being present with it. And that ties directly into another major strategy they hammer home, pacing.
Yes, pacing is crucial.
Which is incredibly difficult for adults to accept. Because, I mean, our entire society conditions us to push through the pain.
Oh, absolutely.
We are taught that fatigue is just a weakness you defeat with a cup of coffee and sheer willpower.
But fatigue in hEDS and dysautonomia is fundamentally different. It isn't just being tired from a long day. It is a systemic energy depletion at the cellular level.
Right.
The body is exhausting massive amounts of energy, just keeping the blood pumping and the joints aligned. When patients attempt to push through this depletion, they trigger massive symptom flares that can literally leave them bedbound.
So you have to listen to your body.
Learning to stop and rest before you hit the wall goes against every societal expectation, but it is the most vital skill an hEDS patient must master.
So what does this all mean? When we zoom out, the reality is intense, but finally clear. hEDS is a complex, multi-systemic genetic condition, firmly anchored by new findings in genes like ACKR3 and SLC39A13.
The evidence is undeniable now.
It is. Yet this profound physical reality was obscured for decades by a siloed medical system that treats the body as disconnected parts and by a deeply ingrained bias that routinely dismissed complex female pain.
And that perfect storm left countless people, particularly neurodivergent women, to navigate an invisible, agonizing web of joint failures, autonomic chaos, and immune reactions completely in the dark.
It truly is a testament to the sheer resilience of these patients. I mean, they survived, they adapted, and they advocated for themselves long enough for the scientific technology to finally catch up to their lived experience.
It really is incredible.
It is. But I want to leave you, the listener, with a lingering thought today, one that builds on this new genetic reality.
Okay, let's hear it.
If this condition is genetic, and it affects up to 2% of the population, well, that is a massive evolutionary footprint.
That is a lot of people.
And evolution usually weeds out traits that are purely detrimental. So what if hypermobility wasn't originally a flaw?
Oh, that's an interesting angle.
Right. What if, in our ancestral environment, having highly flexible joints and a hypervigilant, fast-reacting nervous system actually offered a distinct survival advantage?
Like being more alert to predators or more agile.
Exactly. What if these genetics only became a disorder when we forced these dynamic, highly sensitive bodies into the sedentary, high-stress modern world?
Wow. That completely flips the paradigm. It suggests the failure isn't entirely in the patient's DNA, but in the environment we expect them to survive in.
Something to think about the next time you or someone you know is told they don't fit the mold. Thank you for joining us on this deep dive. Keep questioning, keep learning, and above all, keep advocating for yourselves. See you next time.